If you are just joining us, you missed the dogs in the background, but welcome. We're delighted to have you here today on this wonderful November 1st. Can you believe it is November? It's amazing. So welcome to the eHealth Initiative webinar. We're going to be talking today and featuring two eHealth Initiative two eHealth Initiative members today that we're really excited about, talking about some innovative virtual solutions going on in the industry right now. And we've got some really good best practices to share with you today. As I mentioned, I'm Jen Kovich-Bordnick from the eHealth Initiative. And with us today, I have Lisa Ide, Dr. Ide, who's the Chief Medical Officer of Zipnosis, and Dr. Steve Waldren, who's with AAFP, American Academy of Family Physicians, who most of you have probably heard of. And then we're going to do some Q&A at the end. So we've got a pretty good lineup today to start with. Next slide, Claudia. A couple of issues, and I can see the numbers are going up, so we have more and more people joining us. Welcome. All of you are currently muted. We do want your questions, though. Even though we can't hear you, we want to hear from you. So submit your questions via the chat feature there at the bottom. You'll see it's chat. Just click on that. Send us your comment or your question. Everything's welcome. We want to hear what you have to say. If you're having any technical difficulties, you can feel free to use that chat box as well. And Claudia and Kaylee in the home office will respond to you as quickly as possible with their technological genius and figure it out for you. And if not, refer you to Zoom, who can help you. Questions. Q&A. Again, we're going to use the Q&A in the chat there at the bottom. So give us your questions. And slides. Everybody always wants to know where are the slides, and we're already getting questions about the slides. The slides will be available on the EHI website. Are they available yet, Kaylee or Claudia?
Yes, they are.
Okay.
Yes. We'll send a link. We'll send a link through the chat line.
Perfect. So you are always welcome to pick up any slides you'd like at the eHealth Resource Center online. Okay, and for those of you who aren't familiar with the eHealth Initiative, and everybody should, because this is a member call, so you should all be members, but our mission is to really convene executives and identify best practices in healthcare. And that's exactly what we're going to be doing today, is talking about some best practices in healthcare. And we've got two incredible executives joining us today to do that. Next slide. This is just a sampling of some of our wonderful members. We're so fortunate to have so many great organizations and executives to work with, and we're always looking for more best practices to highlight. So if you like what you see today, if this is the type of thing you would like to share more broadly, and you've got a good example for us, please reach out to me or Claudia, Kaylee, and let us know, because we want to share your stories and your successes. Next slide. And we have a lot going on right now. This is actually, this isn't even quite exactly up to date. We've got a lot of more work going on. This is a value reimbursement, technology and analytics, workflow for patients are just three of the work groups and best practice committees we have right now. We're doing a lot of exciting work on prior authorization, artificial intelligence, machine learning. If any of those topics interest you, or you have something to share or a best practice in that area, please reach out to us, because we have lots of groups meeting and identifying strategies and challenges and ways to work in this area, and we want to get you engaged. So please let us know, and we'll bring you to the table. Next slide. And as I mentioned before, ehidc.org, that is the place to go for any resources. We have added over 600 resources in the last year. Reports, surveys, presentations, blogs, all kinds of goodies in there on all different types of topics that you're going to be interested in. So check out ehidc.org. All that's downloadable for free. And in addition to that, if you have something that you can upload, if you've got a case study or a report that your company's just released, we want it up there. We want this to really be a forum and a platform for everybody to share assistance and education and all kinds of information. So please go to ehidc.org and upload your reports and surveys. And when we see something good on there, like we did today with Zipnosis and AAFP, we will pull it out and we'll do a webinar and we'll highlight it. Next slide. Okay, as I mentioned today, we've got two incredible organizations with us to talk about virtual care, advancing care delivery. We're going to hear first from Lisa at Zipnosis, and then we'll hear from Steve second. But we're really going to hear about the partnership and how they're bringing these opportunities and benefits of virtual care to family practice. And I think this is a really exciting example to share today because there's been so many articles and stories in the news about how we can use virtual care. And this is actually happening in the field. This isn't vaporware. This is actually going on right now with patients. And I think it's really important to share the reality, and it's wonderful that we have a story like this to tell today. So I'm going to turn it over to Lisa, and then we'll get to Steve next. So Lisa, take it away.
Great, thanks. Okay, you can start with the About Zipnosis slide, couple in. And I'm happy to have this focus on the AAFP virtual care product today, so thank you for asking us. I want to introduce Zipnosis quickly, and our mission statement is to provide innovative access to mainstream medicine. And to that end, we are a SaaS company. We provide a virtual care platform. Initially, this was designed to provide this platform to health systems, and you'll see how with AAFP we're branching out to provide that to family practice providers in the AAFP organization. Our software has a strict focus on evidence-based guidelines, and we are able to integrate into medical records, or we're well integrated into many of our health systems. And organic clinical decision support is an integral part of our visits. On the next slide, you'll see that we are currently in more than 30 health systems across the country. We have more than 150,000 visits under our belt and hundreds more every day. We operate in multiple modes, so you'll hear more about that with virtual care in a few minutes, but we initially started with asynchronous visits and now have step-ups to text. We have phone and video, direct to phone and video, so we operate in all the different modes that are possible. One thing we're particularly proud of is our antibiotic stewardship. Because of our adherence to evidence-based guidelines, we have an excellent record of antibiotic prescribing to guideline adherence. On the next slide, I will introduce the general topic of how does virtual care fit into healthcare, and really, my quick philosophy on this is that healthcare happens across the continuum, and virtual care has a place in almost every part of that continuum. For simple urgent care conditions, you can have a visit that's completely asynchronous. As the illness or medical care gets more complex, then you may need to link into brick and mortar, either in the case of labs or into a referral to be seen in person. Some virtual care can be handled in part by asynchronous and then by stepping up to additional modalities. So it does have a place across the healthcare spectrum. And if you flip to the next slide, I want to just take 1 minute to focus on the term of virtual care as opposed to telemedicine. So I think I would differentiate that by saying that telemedicine was what we have had for a while with video and phone, and virtual care encompasses all the modes, and it's very flexible. It's mobile, it's asynchronous, it's chat, versus the slightly older technology of pure telemedicine. So when I speak about virtual care, I am talking about something that uses all the modes of communication. It is extremely efficient for patients and providers, and it keeps embracing technological advancement. So when we recently did a survey of kind of the benchmark status of virtual care, we found that 61% of health systems are really interested in using multiple modes. And the virtual care is also being increasingly integrated right into the health system's electronic health records. On the next slide, you can see in a way what brought us to virtual care. And the consumer expectations outside of healthcare are really changing what patients are expecting in healthcare. They expect to get healthcare anytime, anywhere. They expect to have full connection. They want fast results. And our healthcare patients are pretty cost conscious, just like consumers in every other industry. In one of our recent surveys, we had a 92% satisfaction rate for patients who received treatment via virtual care. And some of that is because they're getting high quality results. They are able to get it on any mode in their connected device. And it's very cost effective because it is so efficient for the providers. In our particular visits, the average we have nationwide is that it takes a provider less than 15 minutes to get to the patient interview. And then they are able to provide their results in less than 2 minutes on a nationwide average. If you look at the next slide, you'll see what it looks like for a provider when they're doing an asynchronous visit. So in this visit, a patient will be answering questions. If you show the next slide, it's there. But the patient will be answering questions on the adaptive interview. The interview is unique to the patient. It adapts with them. And then the provider gets the entire patient note compiled for them. So I'm not seeing it right now, but if you go to the next slide, you'll see, there you go, the provider experience, where the provider in this instance did none of this documentation. This is an asynchronous visit where all of the documentation has been done for the provider. The average time it takes a provider to review this visit and to prescribe is 2 minutes with no typing. They need to click, and then they have the option of inputting a personal message. We had a recent study done at one of our academic medical centers that has our software, and they had a particularly bad cold and flu season last year in their state. They were able to do almost 2,000 upper respiratory infection or influenza visits. The patient experience will triage patients appropriately that need to be seen in person with either serious health conditions or concerning symptoms. But they were able to keep hundreds and hundreds of patients out of their waiting rooms and emergency rooms using this platform. And in the process, because of the fast and efficient visit, they saved over 600 hours of provider time. And at the same time, they had, again, the 95% antibiotic stewardship on their prescribing. The provider experience on a synchronous visit can be a little bit more similar to what we think of as telemedicine. So if you go to the next slide, there's an example of a synchronous virtual care visit where it's in real time. So the patient and provider are connecting synchronously here via video in this example. There is a hybrid version, and that's what we call our step-up version, where the patient starts with the asynchronous experience, answering all of the questions. Because of something they've answered, it is possible that just a few more in-person questions will be able to let them be treated online. And so those can step up to text, to video, or to phone on the Zipnosis platform. And in that instance, 95% of the documentation has all been done for the provider, and they have just a small bit of documentation to do. So on the next slide, you can see what's happening in virtual care, and I would say it's moving quickly. There will be a streamlined vendor environment with fewer companies serving the market, we think, in the future. Clinical use cases will be rapidly increasing. Primary care will be more possible. We think it will be a part of every provider's day, that they will be taking care of some of their patients in person, some through virtual care. There will be increasing integrations into the electronic record, and quality measurements will be increasingly important as well. On the next slide, we're all familiar with the quadruple aim, and there is a clear spot in the quadruple aim for virtual care. Just on the topic of physician burnout and where that might intersect with documentation concerns, virtual care can be a real solution for providers in that area. It also improves patient access. People can get care in rural or urban areas just as easily, and it increases the capacity of providers to take care of more patients because it's so extremely efficient. It's also very cost effective. With all of the time saved, you're able to treat people who can be treated online with that most efficient method. Those who need a little more care can take a little more time, and eventually the correct people will be triaged to be seen in person. So we think virtual care really meets all of the quadruple aim. In the next slide, you'll see how that in particular might relate to the provider shortage. And again, that goes back to that efficiency study we did at our partner, where I mentioned those numbers of 1,995 visits being able to be done at 2 minutes each. Now, some of those were triaged in person to be seen, but then you're ensuring that you're getting the correct patients to be seen in person, and those who can stay home are able to do so. On the next slide, I want to just mention that we originally made the solution that I'm talking about, our virtual care, for large health systems, and as we were gaining experience in that across the country, it became clear that this wasn't an option for a small practice. They weren't able to use a large enterprise system. And I'll tee that up for you, Steve, to talk about your experience at AAFP looking for a solution for family practice providers.
Oh, great, thanks, Lisa, I appreciate it. So what I wanted to do is talk a little bit about kind of the process got us to where we're at today, where we launched AAFP Virtual Care in September. So in the next slide, we'll kind of give you a little backstory. So just for those few maybe that hadn't heard about the AAFP, we're a membership organization of family physicians, about 131,000 members. Of those, about 71,000 are actively practicing family medicine. And in 2014, we did a survey looking at our members, and about 15% or so were using some type of virtual care in their office. And we were seeing that kind of growth starting to happen, not only in the industry, but also in our membership. We also saw the growth of value-based payment that was doing two things. One, it was freeing up physicians to be able to think differently of how they would provide care to patients and not tied to what would get paid for in a fee-for-service model, but also how do you expand the capacity of your practice and extend it outside the four walls of your office to the day-to-day operations of patients and their lives. And then finally, we're seeing that there's a kind of a continued fragmentation of primary care with a lot of the standalone telemedicine offerings. So our goal was to try to make it easy for a traditional brick and mortar family medicine practice to add telemedicine and virtual services to their practice. And we wanted to be sure that we were focused on solutions and not just a platform. So we'll talk a little bit about some additional things other than just the platform that we're trying to put together, working with Zipnosis. It was very important for us to make sure that it was evidence-based and that it would be able to be implemented by smaller practices that didn't have an IT infrastructure or a director of marketing that would be able to get this service deployed out to their patient panel. And then lastly, how do we make sure that they're situated in a way that they can be successful with the growth of value-based payment and extend what they can do in their practice? So on the next slide, we talk about what we did to actually develop the product itself. So we sent an RFI out probably in September of last year, not last month, but a little over a year ago, to a handful of partners that we thought would be good opportunities for us to work with to create a product for our members. Of those, we found Zipnosis, which we thought had a great platform, was kind of focused on the enterprise, but it did check mark all our boxes and what we were really looking for. Another thing that we're really pleased with is that they were really focused on making sure that it was a delightful workflow for the physician, which is really important for us, especially as being a membership organization. So we worked with Zipnosis to create a joint product offering, taking their platform and creating kind of a retail model instead of an enterprise model to deploy it. We found 8 practices throughout the US that are members to try it out, from small to medium-sized practices, even a DPC practice to come in and take a look at it. And then working with Zipnosis, we tweaked it as we found that new things that we didn't think about when we started to put the platform together. But in the most part, I would say 95, 97% was where it needed to be. And then we launched the project to our members in September of this year, just a little over a month ago. So next slide. So currently, what we have is a kind of a retail onboarding process for new prescribers that we worked with Zipnosis to build. We are focused on the asynchronous visits, where wanted to make sure that we didn't disrupt the workflow inside practices as they're adding this into their practice. And the asynchronous visit is a way to really do that. And as Lisa talked about, you're talking about less than 2 minutes to be able to take care of these acute care issues via the telemedicine service if you're just using the asynchronous piece of it. So you don't have to change the way that you schedule, think about who's going to cover what. You're able to open up your kind of virtual storefront to the hours that you want to, but not have to disrupt your traditional kind of practice. And then once you get used to that, then you can start to add in a lot more of the synchronous modalities that Lisa talked about, the step up and the direct-to-video pieces of it. Also for us, it was important to make sure to support practices to be able to deliver evidence-based care. So really like the idea that everything was protocol driven. Once the physician made the diagnosis, then it was very easy to say, based on that diagnosis, here's the evidence. And very quickly, with a couple of clicks, you're able to give evidence-based care and have the note generated and the patient instructions really generated as well. And also, one of the things that we really wanted to add, again, outside of just it being a platform, is provide support for them to market the service to their patients. So working with Zipnosis put together a media kit that the practices were able to deploy out to their patients and be able to use Facebook and Twitter and other things to announce this new service that the practice has. So where do we really want to go for the future? We want to continue to expand the protocols that are available for the acute visits, for things that are important to family medicine and our patients. We want to really work with Zipnosis on adding some of the additional features. So again, we wanted something that was entry level, that was easy, that was not disruptive, and that could be deployed and implemented quite easily. But as we're looking at that, as their ability to add additional functionality, maybe in additional packages moving forward. We also want to be able to support the chronic care with that delightful workflow. So right now you could do chronic care through the system using the direct to video, but we want to work with Zipnosis to be able to figure out how to make a really delightful workflow for taking care of your chronic patients over that longitudinal care. And lastly, try to continue to improve the enhancements for integration of payment with EHRs. In the enterprise model, the business models are there to deal with the lack of interoperability that we have in the industry. But for small practices, that's hard to do. And we have about 30 or so different EHRs our docs deal with. So we've not solved that problem, but it's something that we'll be working on with Zipnosis in the future. The next slide. And the next slide. So I'm happy to answer any questions that you have around our partnership. Again, like I said, we just got it launched in September. Just got some of our docs using it. I got a lot of great feedback from our pilot folks. Maybe a couple other logistic things that we didn't talk about. We wanted to make sure that the practices were able to set up their pricing structure they want. So some of our docs may decide not to charge for the patients for this service. Others may want to, and they're able to set up the visit kind of a fee schedule that they think is most appropriate for them and their patients.
Steve, can you talk about the types of practices that are actually using it right now? Any trends that you're seeing? I guess success, is it catching on?
Yeah, so again, what we try to focus in on is the smaller practices. So, if you're less than 20 physicians, but mostly if you're less than 10 physicians, that's where we are really trying to focus our product on. You do need to have an AAFP member in your practice, but not all the physicians or mid-levels, anybody that would prescribe drugs, do not have to be a member of the AAFP to participate, but you do need to have at least one to be able to have access to the platform. So we're seeing some of the smaller practices enter this in. We've seen a lot of interest in our practices that do direct primary care. Actually, one of the practices that was in the program for the pilot has probably been the biggest champion and really has taken off with it. His patients are loving it and are very eager to pay the fees that are needed there so that he's able to provide enough value that is going on quite well. We found that a lot of our other docs are kind of a little bit slow to kind of get it, once they got it implemented, and actually get the utilization up. So we'll continue to look about ways of helping them get best practices on how to add this to their practice. And we're hopeful that that will improve with a lot of the changes that will be made during the pilot process as well.
Lisa, do you see any trends with the folks that use the product, the asynchronous, the synchronous, and what types of practices adjust it well, or what types of patient populations?
So what we found from our initial pilot practices is that they want to do more and more with it. So they started with the asynchronous ambulatory care protocols for upper respiratory infections, dermatology conditions, and other things you might see in a ambulatory care or urgent care setting. And the interest is to continue to do those, but to be able to take care of some of their patients with chronic illnesses also. So some of them are interested in doing that through direct to video, and then we'll be able to be working on specific protocols for that as we go forward.
And what about reimbursement, I guess is a good question for both of you. Are asynchronous visits reimbursable? What's that look like? Steve,
so that is a little bit, that's a little bit state dependent, and Steve, I'd love to have you chime in when I'm done, but the regulation is different in different states. Many of our health system customers have priced the visits to be slightly less than a copay, so many of those are cash pay and not in the market for reimbursement. But some states, depending on the state, will have reimbursement for asynchronous visits.
And our focus was on to make sure that we had something available for every member in all the 50 states. We focused on a model that allowed the patient to be able to pay for the service. If the practice wants to get that reimbursed, then they would have to do that out of band. Again, that's something that we're looking to add in the future, but it's something that's not available currently in our piece. Zipnosis has those capabilities, but we've not implemented in AAFP virtual care.
How much does a patient typically pay for a visit?
That's up for the provider to set for themselves. I think in the family practice group right now, it ranges from $25 to $75 for a visit. Does that sound right, Steve?
Yeah.
Surprising to us is that the physician who decided to charge $75 per asynchronous visit is by far our busiest physician doing the most visits. They also have the ability to charge different prices for their direct-to-video visits versus the asynchronous visits. But that's part of the AAFP virtual care product, is that it's flexible and configurable for different family docs. So they can decide what hours they're going to open their virtual care clinic, what they're going to charge for it, if they want to do purely asynchronous or open it up for the step-up and direct visits also.
Can you talk a little, oh, sorry, go ahead, Steve.
I was just going to say the practice that was charging the larger amount also was in a rural area. So in there, the value not only of being able to see the physician, but also not to have to drive 2 hours to see the physician for a 5-minute visit and turn around and drive 2 hours back home. So again, I think the value is where you need to figure out what the price point is. And we have some of our practices, I think, also that will not be charging as part of the ones that participate in some ACO or some of our direct DPC. I didn't want to say DPC, I wanted to say it, but now I can't remember what it actually stood for a second. But for the DPC practices, you may want to bundle that all in. So you can charge $0 if that's what you wish to do. Or if you want to try to do that through the insurance as well and build that out of band, you can definitely do that.
Okay. Can you talk a little bit, you just mentioned for follow-up visits, what other types of visits are common? What types can they see and what will they not see generally?
So if they're sticking with the purely asynchronous, those are what I would call ambulatory care visits or urgent care visits. So those would be our most common ones are upper respiratory infection with influenza. We have bladder infection visits, conjunctivitis, oral mouth sores, and a number of dermatology visits, as well as an open dermatology visit, or I don't know what my rash is type of visit. If they use the direct-to-video capabilities, they're able to see anything that the family physician feels comfortable treating without needing to see the patient in person or to get lab tests. So that one is open.
What about children?
The various protocols go down to quite young ages, depending on the protocol. So I might just use this for one moment to say we have a National Clinical Quality Advisory Council that comes from leading doctors across the country who have been advising us on our protocols, and we recently expanded our age limits to go a little bit younger on a number of protocols. So some of the protocols go down to age 2 or age 6. Some are at 18. They have different age limits depending on the evidence-based guideline and what you're able to treat. So there are many of the protocols that are appropriate for pediatric patients.
So we have a couple of questions about behavioral health and psychiatry. Is something that can support that?
So the particular platform can support that right now through the direct-to-video visits, that you could do mental health counseling through direct-to-video. The AAFP doctors are family doctors, so they're not psychiatrists, but our main Zipnosis platform can absolutely be used for behavioral health.
And there's a lot of good evidence, too, in using virtual care for behavioral health, that actually, even using some of the asynchronous pieces, that patients feel like they're not going to be judged by the computer. So they're more open with the way that they answer questions, even with physicians that they know. So I think adding that behavioral medicine component is really important for us as we continue to look at enhancements to the program.
And I know, I think it's the VA has had a lot of success doing therapy online, even group sessions online with the virtual. So I think there's probably a lot of good examples out there, and you can probably find some of those in our resource center for the individual who asked that question. Another question we have is just to check, are you talking about doctors seeing people on their devices at home, or are you talking about them doing it in their offices?
Yeah, so that's really important. In the parlance, the originating site is the patient's home or work or vacation. It's not another medical facility. So again, kind of why we didn't talk beforehand, but I'm assuming why we both, Lisa and I both talked about virtual care and not telemedicine is because a lot of time when people think about telemedicine, that they think about that there's another facility the patient goes to and sees some specialist in a far off facility. What we're talking about is the patient is at home, or if they have an office at work that's secure, or if they're on vacation, it's not another facility.
Are the doctors
and
primarily?
that question might have been geared towards providers. The providers can be anywhere when they answer the visits. They can be anywhere where they have a phone on them. The visits are easy to do on the phone or a laptop, but the majority of our health system providers are doing these visits on their phone, and they're doing them from anywhere. I think actually just recently we were at the Family Medicine Conference in New Orleans, and there were a couple of physicians there who had the platform up and running, and they were able to do visits while traveling on their phone.
That's excellent. That's great. Question for you, Lisa. With the full functionality of Zipnosis, do you guys have any kind of capability so that you could get a new patient in following this, or is it actually primarily with existing patients that this is happening? Is there any kind of interface with scheduling or insurance, or tell us about that a little bit.
Sure. So the full Zipnosis platform that is appropriate for a health system or our enterprise software has many other features that are not currently in the AAFP virtual care, which is geared for smaller practices. So we have the ability to do claims utilization. We have the ability to do specific routing, to link to scheduling, whether it's online scheduling. We have the ability to link to a patient outreach. So if someone is triaged, we can link to a health system's call center or nurse triage line, so that you can do a warm handoff from the triaging system right into the health system for a call. We are absolutely able to see new patients. There is some state-by-state regulation on that. So for the AAFP product, we have made it uniform that new patients can be cared for, but we'll need to have a quick step up to video to meet the regulatory requirements across the country. But in our health systems, we are specifically following the correct regulations in each state. So sometimes that means you can see a new patient purely asynchronously, and sometimes it means you need to have a synchronous communication to establish care with a new patient.
Great. Steve, when the physicians are looking at this, are they also seeing the patient's medical record? How does that work?
Right. So for any established patient, then yes, if they have the medical record, then they're able to view that inside their EMR. Now, there's not integration, so they're not able to see the record inside of the Zipnosis product. But again, right now with the acute care visits that we're focusing in on, the patient is asked the appropriate questions to answer those. So we do have access to that particular information. The other thing too is once you have that note that's generated, that is pushed to a file that could be then uploaded into the EHR. Again, we could have worked with Zipnosis on the integration as they have that as part of their platform, but then the cost would be outside that, which would be supported of a smaller practice. So that's why we don't have that integration.
And that's maybe worth just a quick minute on, Steve, as well, is that we really wanted this to be affordable for family practice doctors across the country in small practices. So that's one reason we limited some of the bells and whistles here, so that this could really get in the hands of family docs who are working in small practices without as many resources as a big health system.
Makes a lot of sense. Do either of you know what states are allowing video visits with Medicaid or visits?
I don't.
Okay. Just want to ask all the questions.
Yeah, just for that person too. One resource you may look for is the National Resource Center on Health IT or on telemedicine policy, and they do have kind of a map with discussion of kind of each of the states. And I know the American Telemedicine Association also has some policy stuff on their website that does talk about each individual state. So I don't know that it gets specific to Medicaid though.
That's a great question. Actually, Claudia and Kaylee on staff here, maybe we can find the answer to that and post that for the participants today. That would be really helpful to know. All right, let's see what else we have here. Do patients have to have access to broadband to be able to do this?
I mean, no, for the asynchronous, you do not. Video, I'll leave it to Lisa to know how much bandwidth that you would need, but you don't need a gigabit service for sure.
And I'm not sure I can give the technical details on what you need, but I will say we have it successfully up and running in multiple states across the country, but I don't have the technical specifications on that.
Yeah, and none of the practices in our pilot that I remember ever having a patient say that there was connectivity problems that limit them from being able to access the platform.
And Lisa, I think you kind of started to answer this question before, but we have a more specific one about how to make this affordable in ambulatory practice for folks that have fewer resources, I guess. Is there a way to make, tailor the contract for small practices?
So this AAFP product, if you're an AAFP member, is the way to make it affordable for a small practice. I don't know if you want to get into the specifics of pricing for it, Steve, or not, but it is really very affordable. Our health system versions are just too much for a small family practice group to take, and that was really the impetus behind this, I think, from AAFP, was to be able to get something into the hands of their members in small practices.
And there is a setup fee depending on the size of the practice. So again, we tried to step that up so that we could get it the lowest for the solo. So our solo practice, so there's only going to be one user of the platform. It's $299 for an initial setup. That gets you all set up, gets the merchant account, and all that kind of set up. And then it'd be $159 a month. You do have to sign an annual contract, and you're ready to go. You get a free kind of admin account as well. If you're a larger practice and want to add in additional admins to kind of manage things for you, that's another $45 a month to be able to do that.
That's great. And just as a follow-up on that, so if a doctor wanted to start getting services, kind of how long does it take to get set up and see your first patient?
It can be very fast. It can be, I think the fastest we've had is 10 days. Is that right, Steve? It's a self-paced program for the AAFP physician who wants to get going. There's a training piece, and they can go through it at their own speed, which can be quite fast.
And another plug for Zipnosis, and in their training, the piece that they've built, one of the things that they've done for others and also with AAFP Virtual Care is they send out test visits. So once you're set up and you're ready to go, you're ready to be live, you give Zipnosis a time frame that you're available, and you go about your regular day, and you will get a test patient. It will come across looking like a patient. And you go through the whole process. So then you know that, yes, it all works. I know exactly what to do. So when you have that first patient, it's extremely smooth for that particular patient and for the provider.
Oh, that's great. So a test patient, that's a great idea. Just as a follow-up on that, you know, how long is it taking doctors to get comfortable with this, particularly doctors that aren't technology experts?
Yeah, and I think, again, one of the testaments to the Zipnosis product and why we went with them as a partner is they've really thought through the process and make it very delightful, very easy, very thoughtful for the provider. Through the process of the pilot, everybody went through the training without problem. Nobody really had any problems being able to use the system. And again, in regards to getting the level of comfort, our doc that was the DPC practice, I think he was comfortable within minutes. A couple other docs took a little bit more, but again, they were able to do those live visits and get that comfort level before they expose that to their patients. I think the real challenge is being able to help the physicians be able to make the service aware in their patient panel. So having the store open doesn't mean that they're going to come to your website and start asking for visits. You do need to market the service to your patient panel, let them know that it's coming. So I think that was the one thing that caused the most delay. That, in addition to just busy practice and being able to stop what you're doing and do the hour or two training that you need to do, and then come back to practice.
That's a great point, Steve. So how are the physicians actually marketing this? What's the most successful way, or what are some things they're doing?
Yeah, I think social media was definitely a way that we found that even for the smaller practices, it seemed like to put stuff up on their website took some time and energy and effort, but to put something on their Facebook page or on their Twitter account, you do that kind of all the time. So being able to advertise there that you have this new service, I think was probably the best way to do it. And again, what we did was we provided them with media parts that they could then reuse for their practice to talk about virtual care in general and about how they're providing this service to their patients.
We also think that the recommendation of your own physician to use this service is one of the most important things. So I would suggest that AAFP docs who are starting out in virtual care say to their patients that when they see them in person, is happy to take care of this for you in person today, but next time know that you could stay home and have something like this taken care of. And that kind of education will take a little while, but once their patients realize how convenient it is, they will see their numbers increase.
What are the laws in terms of doing visits out of state? Do your patients have to be within the same state that you're licensed?
Yeah, so it's the same thing to be able to practice medicine for the most part. Now, there may be some additional restrictions in particular states on restrictions on telemedicine, but in general, it's just as if you could provide the service, then you'd be able to provide the service via telemedicine, just like if they were on the phone. So each state may be a little bit different, so you definitely need to figure out with your particular state what the rules are.
In general, a patient is, if they're a patient of that practice, is in the state as the physician where the physician is licensed.
Okay, great, thank you, that's helpful. A question about workflow, and I think you kind of addressed this at the beginning. So one of the reasons it sounds like you picked this product, Steve, was because you wouldn't have the workflow. So Lisa, I guess one of the questions is, how have practices changed their workflow actually, or have any of the practices you worked with actually had to change the workflow in terms of incorporating virtual care?
So the ones that are doing asynchronous visits with the 2-minute time and as an average for the visits have just fitted into their regular day. They haven't had to change their workflow. Now, when they do some of the direct to video visits and branch out into that, they will need to change their workflow. We are working on a way for those to be scheduled into their workday, and that will come with our primary care and chronic care visits to be able to schedule those. But right now, the ones doing asynchronous, it really just fits into what we call their marginal capacity during the day.
So are most of these happening during office hours then, not off hours or evening hours?
The family physician can set, as well as our health system, can set the hours of their virtual care clinic. Many of them want to set it just when they're in clinic so that they know in the hours of their clinic, maybe 8 to 5. Others might want to be able to cover visits like this in the evening time. And some of our health system partners go 24/7. So that the timing is really up to each family doc's desired schedule with the AAFP virtual care visits.
Great. We have a question here, which I think I know the answer to, but about if patients need to pay to set up the connection and the hardware. And I think what I heard is that there's a fee that you pay the physician if you would like to use or do a virtual visit. You don't need to set up a connection or a hardware with them. So anybody who has an internet connection can do a virtual visit. Is that correct?
Yeah, you need an internet connection and a browser.
Yeah. Okay. And I do want to share, Teresa Wilkes, thank you, Teresa, has sent us a link that has the current state laws and reimbursement policies for telehealth. So we'll send that out, Kaylee and Claudia, with a link to the slides today so everybody can find that information as well. Thank you so much, Teresa. That's really helpful. What about other types of clinicians? Is it just MDs, or Lisa, do you have other kinds of medical professionals? I know we mentioned therapy before and behavioral health, but what other types of clinicians are using this?
An advanced practice provider. So we have nurse practitioners and PAs who are using and staffing this platform, and MDs.
And if somebody wants to find out if their doctor is using telehealth, is there an index, or is there a way to figure out, Steve, if they want to find a family physician who does this? How do you do that?
Yeah, so if they want to know if their doc does, then the easiest way is to ask. You could try to go online and see, but they may not have put it in the best place, unfortunately, which is one of the kind of best practices that we're working on. But in regards to finding docs that want to do this, unfortunately, I don't know of any kind of resource that we have that would denote which docs would do that. I think our philosophy has been that we want to make it so it's easy for all our members to use products. They don't want to use the AAFP virtual care product, but want to use a different one, that's great too. But we want to make it so that it's not like, oh, which doc has telemedicine? It's rather what type of telemedicine does this doc provide? So we haven't looked to do any type of provider directory around telemedicine.
Okay, and are there any challenges around connectivity you've had with clinicians in areas where there isn't maybe great internet connectivity, or are you primarily using this in more urban areas?
Yeah, I mean, I think that's one of the things that if you do have connectivity problems at all, then you're gonna have issues here. So if you're there's a particular place when I'm driving for my cell coverage that for about a mile I don't have any service. So if you're in those areas, you're not going to be able to do that. One thing that we did set up was ability for the practices to set their service level agreement with their patient. So when the patient requests a visit, they know in what time that they will be guaranteed to get the response back, or that won't happen. So either that being 1, 2, or 4 hours. So if you are a physician that are in areas where you're going to have spotty coverage, you'd be able to open that up just a little bit. But in essence, if you have a decent internet connection, you're good to go.
And that's a nice example, Steve, of one of the changes we made with the pilot, is that typically Zipnosis has had a 1-hour service level agreement for our health systems across the country. And in the big health systems where it's maybe staffed by an urgent care doc who's at work, that 1 hour was fine. During the pilot, the busy family physicians suggested that they wanted some level of flexibility in that service level agreement. So with the pilot, we did make up that they could either do 1 hour, 2 hour, or 4 hour. So it gives them some leeway, both in connectivity, but also in their workday if they're a solo practitioner.
Which is actually a nice lead into the next question, which is about if a clinician wants to have some kind of after hours physician care support, or is there anything, any way that they can support after hours patient care? Is there a team, a clinical team that they can use?
Yeah, so our focus is on those practices that want to add telemedicine to their practice. So we don't have a group of physicians that will cover anything like that. We have had some docs call us and ask questions about, well, I don't have a practice, but I have colleagues that have a practice and I want to provide telemedicine to that practice. So we're having some conversations now that if you had a place that all those patients would have to be able to get their longitudinal care from, and it was their routine care, and that's the where you're providing the telemedicine for, we'll look into that. But right now, you need to have a brick and mortar practice to be able to use the AAFP virtual care.
Lisa, anything you want to add on that?
No, that is correct for the AAFP virtual care. I will say for our health systems, we have a national clinical network. If the health system does not want to staff it fully, either fully or maybe just in the night hours, we do have a national clinical network, United Concierge Medicine, where we can have a RAF network for our health system partners. That again is a health system specific, and the AAFP virtual care product was for family practice docs to take care of their own patients. So most of them who are doing it out of clinic hours, again, for the asynchronous visit, we find doctors who are doing it while they're out and about in their daily life in the evening, maybe at kids' sporting events or wherever they are, because all the documentation is there. There's no typing needed on the phone, and it's a very easy asynchronous experience.
And a question about documentation. Does the documentation go right into the medical record following the visit, or how does that happen?
Yeah, so not right into the medical record, but once you are done, there is a file that's created that then can be uploaded into the EHR. Again, to keep the cost to something that's appropriate, we weren't able to get the interfaces with the 30 or so EHRs that our docs have in their practices.
All right, well, that's all I've got for questions here. We had a lot of questions today, so thank you, participants. Lisa?
Hey, Jen, I've got one question. Jen, if it's okay. I was just wondering how, through as long as you've been doing this, what the impact has been on patient engagement.
Yeah, and I think it's too early to know what the level from AAFP virtual care. I'm sure Lisa maybe has something from the Zipnosis piece in the enterprise partners they work with. But the anecdotal stuff has been good, that the patients that are using it like it, that there's that convenience, and that they're seeing their doc. They don't have to see some doc that they don't know to take care of their acute care needs.
And from our platform as a whole, we have we've got really excellent patient satisfaction rates. We also have data on patients who do one visit and how often they will come back and do another visit. So that once they have tried virtual care, they seem to be coming back.
Lisa, do you want to make any final comments, or Steve, before we close?
I would just add that I'm really excited about this opportunity with AAFP, so that this technology can go out to smaller practices across the country. We think it's the future of the way people are going to be providing care, is mixing up virtual care with their regular brick and mortar practice, and AAFP have been terrific partners in working on this together.
Yeah, and we're just excited to be able to provide solutions that help our members take care of their patients in the best and easiest way they can.
Well, it sounds like a fantastic project, so thank you for sharing it with us today. We are going to send out the slides, and we'll send out a link to some of the policy rules in the states and reimbursement, so folks have that, and this will all be available in the resource center. I want to thank both of you again, AAFP and Zipnosis, for sharing with us today, and thanks to everybody for joining us.
Thanks,
Thank you.
All right, this concludes our webinar.